So the role of Daratumumab in the management of patients with multiple myeloma, I think that covers not only the upfront setting, but also late advanced stage of the disease. At ASH meeting, we had the opportunity to see an update of the GRIFFIN study, in which Daratumumab has been added to Bortezomib, Lenalidomide, and Dexamethasone as part of the induction, as well as consolidation, and even as part of the maintenance therapy. And this GRIFFIN study showed how the addition of Daratumumab to VRT as part of induction, consolidation, and 1 year of maintenance is able to increase the overall response rate, complete response rate, and proportion of patients achieving minimal residual disease negativity rate. The follow-up is short enough, so we don't have any data yet in terms of progression-free survival, as well as overall survival in terms of superiority. Another important study based on Daratumumab is an update of the MAIA study, a Phase III clinical study conducted in newly diagnosed myeloma patients non-eligible for autologous stem cell transplantation, in which Lendex was compared with Lendex plus Daratumumab. And the median follow-up right now is over 4 years. And the good news is that the median progression-free survival has not been reached yet in the Dara Lendex, so the benefit is consistent. Definitely the overall response rate is around 93%, and the proportion of patients achieving complete response rate is over 50%, with more than 1/3 of patients achieving minimal residual disease negative. So I think that we need a longer follow-up, but definitely with a median follow-up of 4 years, the benefit is consistent and the benefit continues being demonstrated. And another important abstract presented around Daratumumab is the role of minimal residual disease negativity sustained over time in the transplant-ineligible newly diagnosed myeloma patient receiving Daratumumab in combination with either Bortezomib, melphalan and prednisone, or Lenalidomide and Dexamethasone. And the role of sustained minimal residual disease negativity is going to be able to select a subgroup of patients in which the outcome is going to be excellent. And this is what it has been reported in this abstract. Well, approximately 15-20% of the patients are able to sustain the minimal residual disease negative 6 months and even 1 year after the first determination. And in both studies, when this occurred, the median progression-free survival has not been reached, but the outcome in terms of both progression-free survival and overall survival is excellent. And from my personal point of view, I think that this sustained minimal residual disease negativity rate will be an excellent surrogate marker in order to identify patients potentially cured in multiple myeloma.